And I think we're ready to get started, aren't we, Christy? It's 12 o'clock, and I know I appreciate everybody coming today. We've been really focused on making sure that we cover all different components that may matter when it comes to billing and implementation of telebehavioral programs. And so very excited to focus on long-term care with this session. And just as a little bit of a teaser, really excited. We will have one more session in November. And because of Thanksgiving and everything else, it will be next Wednesday. And I hope on the 17th, I hope you'll come, because we'll be going through the CMS proposed 2022 physician fee schedule, which will be very important. And, just really excited to hand off to Rochelle today, who I'm constantly reminded has many more abbreviations after her name than me. And that's why she's such a good expert to present this information. So let you go ahead, Rochelle.
All right, sounds great. So today, what we've been trying to do throughout the year with these sessions is to have one topic that's sort of geared towards a particular type of care or service or provider type, and then something that's generally applicable to everyone. We've touched on some topics that involve long-term care throughout many of those sessions, but I wanted to take a moment today to focus on kind of start through finish from even going into the long-term care setting, some of those initial visits, things that you can do related to telehealth in the long-term care setting while the patient's in the facility, and then kind of afterwards, and integrating concepts of general telehealth for some of the mandatory medically necessary visits while patients are in long-term care, with some of the ideas of integrating primary care with behavioral health, all focused on the long-term care setting. So that's what we're going to do today. Incorporated into this are some changes that I'm going to talk about in a lot more detail next week when we talk about the physician final fee schedule that just came out last week. If you are on Medicare listservs, your email may have been blowing up in the last 10 days. There was the proposed fee schedule that we talked about back in July was finalized, that goes into effect January 1st. 2,700 pages that came out last week on those final changes that are going into effect in less than 60 days. There was a surprise billing rule that came out. There were vaccine mandate rules that came out. So all of those things kind of play into the topics we're talking about today and next week. A couple of updates, not necessarily limited to long-term care, but in October, the public health emergency was officially renewed. So that's extending into January 2022, barring some kind of affirmative revocation prior to the next 90-day period expiring. Originally, the impact of that going into January was that some of the services that are currently temporarily allowed via telehealth, that are not normally allowed as telehealth services outside of the public health emergency exceptions, would be allowed through the end of the calendar year when the public health emergency ended. So we were anxiously awaiting what happened in October to find out whether some of those services were going to end 12/31 of 21, or if we were going to have another 12 months of availability for those telehealth services. Knowing that the public health emergency in all likelihood is going into 2022, that gives us some assurance that we've got at least another 12 months. However, as we'll talk about next week in a lot more detail, the final physician fee schedule that Medicare just released last week actually extended that out even further, so that many of the temporary telehealth services will be covered through November 1st, 2020, regardless of when the public health emergency ends at this point. So that's something to be aware of. We'll talk again, we'll talk about that in the final, in the session next week about the Medicare physician fee schedule. please do mark your calendars for that session next week. It was a 2,700 page rule in the Federal Register, and we're going to talk about what was proposed. There were some fairly significant changes from the proposed rule to the final rule. A few of those I'll talk about today as they pertain to telehealth in the long-term care setting. And then there are some clarifications on previous provisions that we need to know about as well. So that should be, it should be a challenge for me to cover that in 60 minutes, and I'll do my best next week. So I hope you can join for that. And then also last week, I mentioned that the Department of Health and Human Services released the interim final rule on mandatory COVID vaccines. And this applies to healthcare facilities. So this applies to hospitals, it applies to long-term care. And I wanted to mention that in this session in particular, because the long-term care communities that I work with, ranging from independent living, memory care, assisted living to skilled nursing facility care, have been anxiously awaiting this rule being published, concerned with how it's going to impact their staffing, which is already in a pretty dire situation. And now with vaccines being mandatory for those workers, there's a lot of question about how they're going to maintain their staffing levels in the long-term care setting. I've got a link to the rule. When the slides go out, you can access that final rule. It's beyond the scope of what I'm going to talk about today, but do take a look at that. I will mention one exception to the vaccine mandate that may be particularly pertinent in the telehealth setting, is that it applies to all workers, whether they are employees, whether they're full-time or part-time, whether they're W-2 or 1099, including the staffing agencies, as well as administrative staff who don't have direct patient care responsibilities. An exception to that is if you have an individual, an employee or a contractor who is 100% remote and or a telehealth worker and does not come into the community at all where the patients are located, that's an exception to the vaccine mandate to be aware of. But the rule is that's 100%. That's not 99.9. So if you have a remote office and your administrative folks may periodically go into the long-term care community, that's not a 100% telehealth remote worker, and the vaccine mandate would apply to those individuals. So we could probably have a whole hour-long session on what that means, a couple of dates to be aware of in that rule, especially for those of you in long-term care where data is showing the vaccination rates for employees are a little bit lower than in other settings, is that the first dose, if there's a 2-dose series, has to be administered in the next 30 days. So December 6th, if I remember correctly, is the big day for that first dose. Or if it's a single dose vaccine, then they would be considered fully vaccinated by that time, but they have to initiate the vaccination by that date, or be in the process of requesting a medical or religious exemption. And you have to have policies and procedures outlining how you will ensure that your staff get vaccinated by that deadline, as well as a process for individuals to request medical or religious exemptions, and safeguards and mitigation in addition to those the CDC may already recommend, like face masks, social distancing, gloves, or other PPE equipment to help mitigate any risks for exposure for individuals in the process of getting fully vaccinated. Then the deadline to be fully vaccinated in a 2-dose of vaccine workers is January 4th. So keep that in mind. So we could probably have a whole hour session on that rule, but that's beyond the scope of the telehealth and the coding rules that we're talking about today. But I do want you to be aware of that development. So jumping right into telehealth in the long-term care setting. One of the kind of the key fundamental components of this is where our individuals are located, right? This is where the patients are physically located. So this would often be the originating site for a telehealth service. Now, even prior to the public health emergency, skilled nursing facilities are listed as an eligible originating site. under any circumstance. So as long as the service being rendered is on eligible as a originating. In long-term care, as you well know, we often have kind of a continuum of the levels of long-term care, and that may range from essentially an apartment unit, like an independent living apartment, to assisted living, to a skilled nursing facility and or nursing home. So one of the components that come into play in those continuing care retirement communities or in those various care is whether assisted living, whether independent living can also qualify as an eligible originating site. Typically, outside of the public health emergency, assisted living facilities and independent living facilities are not generally eligible as originating sites because they're more equivalent to an individual's home, which prior to the public health emergency is not an eligible originating site under the Medicare statutes, than they are a healthcare facility like a skilled nursing facility. Even though it doesn't make a lot of sense sometimes, particularly when all of those are occurring within the same physical building, but that's the rules we're working under. When we look at place of service codes, okay, so if you were submitting a professional claim on a CMS 1500 claim form, assisted living facilities have a place of service 13, which is not the patient's home. Place of service for home is we have a rule for telehealth services adding home as an eligible originating site. Okay, so from kind of a technical standpoint, that would often mean place of service 12, the patient's home. So there is a very gray area. There's not clear guidance on this, but individuals who are in assisted living, that place of service is technically different. It's a 13 instead of 12 that we would use for a personal private residence. However, there is some guidance. I can't give you official legal advice, but I will tell you there is guidance in the Federal Register, especially in the new physician fee schedule final rule that was just published last week, that suggests long-term care living arrangements other than a facility like a SNF, assisted living facility as an example, can be considered a patient's home because it's essentially their residence in terms of telehealth billing purposes. There are, just so you're aware, some guidance that suggest otherwise. So that's kind of a gray area that we're working with in the assisted living space. Independent living, though, is different. Independent living, services to an individual in an independent living apartment or unit would be reported with place of service 12, which is the same as the patient's home. And also remember, a couple of sessions ago, I mentioned that there is a new place of service code that was developed to distinguish between telehealth services, our usual place of service 02 that we've been using for years, and a new place of service code 10 that is used for telehealth to an individual in their home. And for purposes of that new place of service code and in the Medicare physician fee schedule for 2022 that was just released last week, there is guidance that on what it means to be a telehealth service in a patient's home. That, of course, that means a standalone private residence, a house, right? It can be an apartment unit that's a private residence. Similarly, it consists of temporary lodging, like a hotel or a homeless shelter. So that's something to keep in mind too, that as we're going to see some guidance, I think, in probably the next 3 to 6 months on using this new place of service code to individuals, to provide telehealth to individuals who are at home. That availability for independent living and assisted living, if in the particular circumstance, it makes sense to consider that the patient's home is only available right now because of the COVID PHE flexibilities that allow us to deliver telehealth to an individual who is at home. It's yet to be seen, depending on how long the public health emergency lasts and whether we have legislation in the meantime that makes home a permanent eligible originating site for Medicare telehealth, whether those flexibilities to deliver telehealth and assisted and independent living levels of care will continue after the PHE. Another interesting component, I think, is that back in 2019, Medicare Advantage plans were able to and have been able to offer expanded telehealth coverage to their insureds, including to individuals at home, as part of their core benefits and not necessarily as supplemental benefits. So Medicare Advantage plans have to cover the same common core benefits and services that regular Medicare covers. They can also cover additional services or supplemental services. For example, they could cover annual preventive exams, like a well woman exam or a well male exam, that are not covered by regular Medicare. They're statutorily excluded. So this change in 2019 made telehealth, expanded telehealth services, including patients' home, able to be provided by a Medicare Advantage plan as a core benefit and not as a supplemental benefit. I think is very interesting because it's not even actually available as a core benefit under Medicare, but that's an expanded feature of the Medicare Advantage plans. So let's kind of talk about a patient going from transitioning into a skilled nursing facility setting, and kind of the initiation of the care in the long-term care community in the skilled nursing facility and how that may look with the provision of telehealth. So as the patient comes into the skilled nursing facility setting, there are certain mandatory physician visits that have to happen in this when a patient's in a skilled level of care. There's an evaluation and management code or group of codes, depending on the level and the complexity of service, for the initial nursing facility care and subsequent nursing facility care. That's referring to the initial visit with the patient. It's a little bit different than new patient, established patient statuses for office visits, for example, where a new patient is one that provider or another provider of the exact same specialty in the same group practice has not seen the patient in the previous 3 years to bill a new patient visit. For nursing facility services, the initial visit refers to the first visit, that admission, even if that provider or another provider of the same specialty from the same group practice has seen the patient in the previous 3 years. Admission specific, not provider specific. Typically, outside of the public health emergency, the codes for an initial skilled nursing facility visit are not allowed to be provided via telehealth. There are some regulations on in the skilled nursing facility conditions of participation with Medicare that mandate certain visits, like the initial visit and a visit every 30 days thereafter, be provided by a physician in person. So this initial visit to certify the need for skilled nursing facility care that's being done by a physician under the regulations typically has to be done in person, face to face. There are flexibilities during the public health emergency that allow that initial need for facility care from a physician to be done via telehealth that are not generally allowed outside the public health emergency. So these 3 codes for initial nursing facility care are temporarily allowed via telehealth, but there are I'll say there's 2 sort of groups of temporary telehealth codes. There's a group that will continue to be covered through December 31st, 2023, with the rules that were just passed last week. There's another group of temporary telehealth codes that will revert back to pre-PHE rules the day that the public health emergency ends, and this is one of them. So the day the public health emergency ends, the initial nursing facility care codes will no longer be covered as telehealth services absent some other change between now and then. And those will need to go back to in-person face-to-face visits. After that initiating visit by the provider, subsequent nursing facility care would typically be used for mandatory visits every 30 days with the patient, or I think the frequency changes depending how long the patient has been in the skilled nursing facility setting, but I'll call it a mandatory every 30-day visit. However, they may also be used if there are medically necessary visits from a physician or other qualified healthcare professional in between those minimum mandatory visits. When these subsequent nursing facility visits are performed via telehealth, they're permanently, even outside of the public health emergency, before the PHE and after, can be delivered via telehealth, but there's a frequency limit. So prior to the public health emergency, a subsequent nursing facility visit could occur as often as medically necessary, but could only be delivered via telehealth once every 30 days. During the public health emergency, that frequency limit is waived. So telehealth as in the skilled nursing facility unit after that first initiating visit. After the public health emergency, there will be a frequency limit, but that limit changed from once every 30 days to once every 14 days. Okay, so that rule has already been finalized, but it has not gone into effect yet because during the public health emergency, the frequency limit has been waived. As soon as the public health emergency goes away, a subsequent nursing facility visit can only be done via telehealth once every 14 days. So I'm going to switch gears a little bit and talk about once the patient is in the facility, we've had the initiating visit, which temporarily can be done via telehealth. And then we may have some subsequent medically necessary visits between the patient and a healthcare provider, which can be done via telehealth at any frequency. Right now, after the PHE, once every 14 days. There are care management services that may also be beneficial to the patient coming into the long-term care setting, whether that's skilled, assisted, or independent living, or even the patient's home for that matter. And one of those is transitional care management. So this is happening generally in the 30 days after the patient is discharged from the acute care setting. And there is a transitional care management it's different than the initiating visit to a skilled nursing facility that's certifying that all the requirements for skilled nursing facility care, the inpatient level is needed. That's generally 5 days or more of therapy or nursing services and all of those requirements, right? Almost like an H&P into the community. That's different, and that's distinct from transitional care management that's really designed to take what happened for the patient in the acute care setting in the hospital, transition them maybe in this case long-term care. So the transitional care management codes, there's two of them depending on the patient's complexity. And there's moderate complexity or high complexity medical decision making. I've got a link on these slides that will take you to new tables that are sort of a way of the American Medical Association creating sort of an objective algorithm to calculate the level of the complexity of decision making to help determine whether it was moderate or high. If it's not at least moderate, if it's straightforward or low complexity medical decision making, transitional care management is not eligible. A lot of the patients that we're going to be seeing coming in just because of that are kind of likely to qualify as high complexity. And generally, because of the acuity of their condition, even if they're going back to assisted or independent, moderate or high complexity may at least apply for this 30-day period after discharge from the hospital. So that link will take you to the new decision-making tables that just went into effect January 1st of 2021 that are different than the way we arrived at moderate and high complexity levels of decision-making in previous years. So what these transitional care management services involved, one of them involving moderate complexity, one involving high complexity, is a communication, an outreach to the patient within 2 business days of their discharge from the acute care facility. That can be a phone call. That does not have to be a full audio visual telehealth service, but that is just making a connection with the patient. That can be looking through the discharge instructions and see if the patient has any questions. Did they fill medications? Have they made arrangements with the long-term care community? Those types of things to kind of help facilitate and ensure the discharge instructions and plan of care are being followed. And then, depending on the patient's complexity, we have 14 days if their complexity is moderate, or we want this to happen sooner, 7 days if there's high complexity decision making. There's a face-to-face visit with the patient, between the patient and a healthcare provider. That face-to-face service can be done via telehealth. What was I going to say? It's not separately reportable. It's captured in the work involved in these transitional care management services. So it's not a separate SNF visit or office visit code. Let me pause there and skim through. I don't see any questions in the chat. If you do have them, free to jump in and ask those questions. Now I'm going to switch gears a little bit to a topic called split or shared billing. This type of service workflow and billing underwent significant changes in the last 6 to 7 months. And I want to kind of give a background on what this billing and workflow concept is and kind of the history to how we got to the rules that we will be looking at going into effect January 1st, 2022. Gosh, that feels weird to say 2022. So when I say split or shared visit, that's referring to when a non-physician practitioner, like a physician assistant or a nurse practitioner, and a physician from the same group practice, both stations on the same day. When a non-physician practitioner, like a physician assistant or a nurse practitioner, have an encounter with the patient and bill for that service, they're paid at a lower rate than a physician would be for that exact same service. They're paid at 85% of the fee schedule. This could potentially be a social worker in the long-term care setting and their lower payment rate that they would typically bill. But when both that non-physician practitioner and a physician from the same group practice both see a patient on the same day, when certain requirements are met, they can combine their work, select a level of service that captures the combined work that they both performed, and it could be billed under the physician's name and number as the rendering provider in field 24 to allow for the full payment of 100% of the Medicare fee schedule. Previously, before these rules are going into effect January 1st of 2022, this concept of a split and shared service was not allowed in the long-term care setting, in the skilled nursing facility setting. Effective January 1, it will be. So I want to go through kind of the background on where we were and how we got to the new rules and how we decide when we've met the criteria to bill for these services shared between a non-physician practitioner and a physician, to bill them under the doc's name and number to receive that 100% fee schedule payment rate. Okay, so again, this is when we've got a general rule for Medicare that only one provider of the same specialty in the same group practice can bill for an evaluation and management service per day per patient. Whether 2 providers of the same specialty saw the patient or 10 providers in the same group, only one gets to bill. And when we have multiple providers with different payment rates, because one is a physician practitioner and one is a physician, both see the patient on the same day. The previous rules were that if the physician performs a substantive portion of the service, the physician could bill the service under his or her name and number. Now, the way the rules were created previously, they were in the Medicare reimbursement manual 104, chapter 12. They were just in an administrative manual. They never went through the rulemaking process. They were never published in a proposed rule, the public allowed to comment, and then a final rule published. So late last year in 2020, there was a body of regulations called the Good Guidance Regulations, really cracking down on agencies making rules in a sort of sub-regulatory way by publishing rules in manual or websites without going through that notice and comment period, the formal rulemaking process. And essentially, if a rule is made or guidance is issued that in effect is a final agency determination on a policy, that is something that should go through the notice and comment period. So back in May of 2021, there was an application to remove the previous rules from the Medicare manual about split shared billing. That includes the rule that said that concept to allow a physician to report a service that has been split or shared between a non-physician practitioner and the doctor, and that it can't be done in a skilled nursing facility setting. That was withdrawn back in May of 2021. So since then, we've sort of been living in limbo whenever a split or shared visit has been provided on what the parameters and what the rules are to determine when the doc can bill for those services. And in the meantime, audits and medical review of those services are supposed to be on hold. We got the proposed physician fee schedule back in July, just a few months later after that was withdrawn, proposing how Medicare would finalize split shared billing in a regulatory way, going through the correct comment rulemaking process. And that was finalized last week, but it has some pretty significant changes over what had been the long-standing rules and policies in the Medicare manuals for years and years until they've gone through the rulemaking process this year. One of the big changes is that it is now allowed in the skilled nursing facility setting when it was not allowed previously. The reason it wasn't allowed previously is that under the federal regulations for skilled nursing facilities, there are certain services that have to perform their entire by a physician. That initiating this with the patient in a skilled nursing facility, those services that temporarily can be allowed via telehealth right now, though under the regulations, that has to be done in its entirety by a physician. It cannot be performed in part by a non-physician practitioner. But under that regulation, there are certain services that can be delegated to non-physician practitioners. So the mandatory physician visits every 30 days after admission, after that first visit, can alternate between a physician and a non-physician practitioner. So on those alternate visits, when a non-physician practitioner can be involved in the service and it doesn't have to be performed in its entirety by an MD or a DO, those services can be eligible to be provided as split or shared, meaning in part by the non-physician practitioner and in part by a physician. And if the requirements are met to bill that split shared service under the name of the physician, you could get paid the full fee schedule rate. In addition to that, medically necessary subsequent skilled nursing facility visits outside of the minimum every 30-day requirement can also be done as a split or shared service between a non-physician practitioner and a physician. They can also, those split or shared visits can also be done via telehealth. Another component that is important in the final rule that goes into effect January 1 is that previously split and shared visits were only allowed for subsequent visits or established patients. Under the new rule, it can be allowed whether it's an initial visit or a new patient. It can be allowed for any patient, regardless of new, established, initial, or subsequent status. Another component that I think is really helpful and really interesting about the new rule is that it clarifies, go back here to this third bullet point. This is the definition of a split or shared service that oh, sorry, I'm skipping around. There we go. Final answer. That a split or shared visit is one in which both a non-physician practitioner and a physician each perform a substantive portion of a face-to-face E&M. Face-to-face does not have to be in person. Face-to-face can be via audio-visual telehealth services. The long-standing interpretation of this phrase that each perform a substantive portion of a face-to-face visit was interpreted to mean that both the non-physician practitioner and the physician have to provide some face-to-face component of this. And in the physician fee schedule going into effect for next year, Medicare clarified that is actually not the case. Both the non-physician practitioner and the doctor have to provide a substantive portion of an evaluation and management service. And the evaluation and management service itself is done face-to-face, but not all of the components have to be done face-to-face. The history may not be done face-to-face. The medical decision-making does not necessarily have to be done face-to-face. So I thought that was a really interesting clarification that in my mind opens the door for the possibility that a non-physician practitioner does all or a portion of the face-to-face piece of an evaluation and management service, but the physician may be contributing to certain non-face-to-face components like the medical decision-making. And that could potentially still qualify for split or shared billing under the physician's name to achieve the higher level of reimbursement. But there's a caveat. There's always a catch. It's not that easy. In order to bill under the physician's name, the physician has to perform the substantive portion of the visit. And Medicare defines that in the final rule as more than 50% of the total time. So in these situations, both the non-physician practitioner and the physician have to document their time, and the physician's time has to be greater. That could be 1 second greater. It just has to be more than 50% of the total service in order to bill it under the physician's name and number. That has practically speaking, has an impact on documentation, because that time element to determine who gets to bill for the service applies, even if the level of the service that you're billing by combining these two professionals' work, their history, their exam, their decision-making, their time, whatever it is. If you are selecting their level based on the key components of history, exam, and decision-making, you typically would not have to document time. But even if you are selecting the level based on key components, they have to document their time in order for the physician to potentially bill if his or her time is greater than 50% of the total. Clear as mud, right? As it's complicated enough, there's a transition year in 2022 where we could use the 50% time threshold. That's going to be the permanent threshold in determining whether or not the physician can bill for a split or shared service after next year. But in the meantime, in this 1 year transition period, you could determine that the physician can bill for a split or shared service based on time, or if the physician performs at least one of the three key components in their entirety. So the physician performs the entire history, the entire exam, or the entire medical decision-making at a level and a complexity that is sufficient to support the level of service that you're billing. Or you could just, for now, adopt the rule that you're going to be basing this on time. Your providers just have to know that in every circumstance, they're going to have to document how much time they spent with the patient. Only distinct time counts. So in looking at that 50% threshold, we cannot count any time that the two professionals are working concurrently to provide a history, an exam, or performing medical decision-making. There will also be a modifier that we have to add to the evaluation and management service. If we are billing it under a physician's name, but it was a split or shared service. And that's going to be a way for Medicare contractors to identify split or shared visits that were performed by both non-physician practitioners and physicians. And I can tell you from reading the final rule, the purpose of that modifier is so the contractors can identify these from a data analysis standpoint and select them from medical review to make sure that the documentation was sufficient to support billing under a physician's name versus the non-physician practitioner. If split or shared visit requirements to bill under the doctor were not met, the nurse practitioner, the PA's time actually exceeded the amount of time the physician spent on the service, then you do not have to add that modifier, but you are reporting that visit under the non-physician practitioner's name and number. You can still use the physician's documentation to help determine the level of service, but it will be subject to the reduced payment rate for non-physician practitioners. Right, so I want to shift gears again, kind of back to the concept of care management services in the long-term care setting. So transitional care management is an example of that, focused on the 30-day period from when the patient is transitioning from acute care into the skilled nursing facility setting, where we outreach with the patient in the first 2 business days. Can be done via telehealth basis, not during the PHE, within either 7 or 14 days, depending on the patient's complexity. And we're going through and reconciling meds and some other activities as part of those transitional care management services. There are other care management services that may be very helpful in the long-term care setting as well. So let's talk about a few of those. Several years ago, there was a new code G9685. And this code was added, it's unique to Medicare, as an initial visit to treat an acute change in the patient's condition in the long-term care facility setting. The goal of this service is providing supplemental payment, a higher rate of payment equivalent to an initial, the highest level of initial hospital care. So it's a very strong financial incentive to have this visit in the long-term care setting, with the goal of avoiding the need to transport the patient to the hospital for emergency care and avoiding hospital admissions or readmissions to the long-term care, or excuse me, to the acute care setting. This service, this visit to treat an acute change in the patient's condition and to assess that and hopefully intervene acutely and avoid the need for hospitalization, was temporarily added to the Medicare telehealth list last April of 2020. But it is among the bucket of telehealth services that is going to go away the day the public health emergency ends. It will not continue through December 31st, 2023. Right, so let's talk about patient care during skilled nursing facilities. Right, patients are often getting PT, OT, speech language pathology services during their post-acute skilled nursing facility care. We know during the public health emergency, the therapy codes for PT, OT, and ST, the modalities, were added to the telehealth list on a temporary basis during the public health emergency only. They have been considered for several years to be added to the permanent list of telehealth services, and Medicare has declined, including this year, to add them to the permanent telehealth list. There's a couple of challenges with this. One of them is that outside of the flexibilities during the public health emergency, PTs, OTs, and speech language pathologists are not among the list of eligible distant site practitioners who can deliver telehealth services. They can right now during the public health emergency, and that's why the therapy modalities were temporarily added to the list of covered health. These therapy modalities are among the bucket of temporary telehealth services that will continue to be available regardless of when the public health emergency ends, all the way through December 31st, 2023. They've also been added by Kansas Medicaid, allowed during the public health emergency, March 12th of 2020. Some of those are even allowed as audio only services, and that policy, that coverage for KMAP will continue to be in effect until rescinded. They were added by Missouri May 21st of last year, and are currently still in effect. So I've got links here to those policies, to KMAP and to the Missouri Medicaid policies when these programs were or when those services were added. The initial evaluation for PT and for OT is actually allowed as a telehealth service, even outside of the public health emergency. One of the challenges, one of the reasons that these have been requested to be added to the telehealth list on a permanent basis is the argument that while the vast majority of the time they are billed by PTs, OTs, and speech language pathologists, physicians or nurse practitioners are also eligible to render these therapy modalities. And when they are rendered by a physician or a nurse practitioner, they should be allowed via telehealth. And Medicare doesn't necessarily disagree with that analysis, but they're worried that because the vast majority of the time they're not done by physicians or non-physician practitioners, but rather by therapists, that adding these codes to the list permanently would create confusion, and they're concerned that would lead to inappropriate billing by PTs, OTs, and STs as telehealth, thinking that they were eligible because the codes are allowed, not realizing that their discipline, their therapy discipline, is not an eligible distant site practitioner on a permanent basis. But answer on that with the caveat that That is one of the many flexibilities that we see in several pieces of legislation at the federal level that have not yet passed, but that are being considered for permanent legislation to make therapists permanently eligible distance site practitioners. I wanted to list several categories or types of services that involve care management that may be really good to think about in the long-term care setting. And we've covered most of these in various sessions over the last couple of months. So you can certainly dive in and find more detail on sessions that we've already covered. But I want to talk about just generally what these services are, and that there are codes for them that are payable by Medicare and may be appropriate to individuals in the long-term care setting, whether that's skilled, assisted, independent, or anywhere along that spectrum. Chronic care management are services that are not actually telehealth. Telehealth services by Medicare are typically those that would be rendered face-to-face, but chronic care management is not a service that's designed to be done in a face-to-face manner. It is a monthly service that can be billed, and it's sort of behind the scenes management of the patient's chronic conditions outside of the face-to-face or telehealth visits, or in between those visits. So patients who have 2 or more chronic conditions expected to last a year or more, have a significant impact on their morbidity or mortality, may be eligible for chronic care management, where you're developing a plan of care for chronic conditions. There's an outreach to the patient throughout the month for chronic care. You're reconciling medications throughout the month. There is member cost sharing to keep in mind. So we do have to get the patient's consent before we enroll them in this chronic care program, provide those services, and bill for those services. Behavioral health integration and psychiatric collaborative care are 2 that we talked about last month. And they're going to continue. Behavioral health integration involves a clinical person that can registered nurse who has some training in behavioral health issues. And it's really designed to integrate plans to manage mental and behavioral health conditions with primary care. And it's a separately reportable service. Psychiatric collaborative care is sort of a step up from behavioral health integration, and it involves a psychiatric consultant, someone who is qualified by their scope of practice to prescribe the full range of psychiatric medications. So that's typically going to be a psychiatrist who's intimately involved in a medication management portion of a patient's mental or behavioral or psychiatric conditions, monitoring those meds. We have a behavioral health manager who's a clinical person on the primary care team that's sort of the interface between primary care provider and the psychiatric collaborative consultant. And all of those professionals in the team are collaborating to manage the behavioral health conditions. We've talked about remote patient monitoring, which are services that can be done provided and billed on a monthly basis, and it involves monitoring patients remotely and their physiologic conditions. So this could be monitoring temperature, for example, to look for signs of infection post hospital care. I can absolutely see some significant benefits to that in the long-term care setting. This involves a device that is collecting the patient's temperature and transmitting that data to the patient's healthcare provider. So it's not necessarily the nursing staff coming in and taking the patient's temperature as part of their normal daily vital signs. This is a device that's transmitting that data automatically. That could be the patient's weight if we're monitoring, congestive heart failure after the acute care setting. It could be blood pressure. It could be glucose. You name it, those physiologic parameters could be remotely monitored, and that could be separately billed. There are 3 codes for those services: the initial education and setup with the patient, the supply, a code to reimburse for the practice expense of the device as a supply item itself, and then monthly monitoring. New in 2022 are a very similar set of codes that are counterparts to remote patient monitoring, but it's called remote therapeutic monitoring. You're going to see this called RTM. Now, RPM codes are they're set in the evaluation and management section of the code book. So a limitation to those, while they can be primarily performed by clinical staff, they have to be supervised and billed by someone whose scope of practice allows the performance of evaluation and management services. So typically that's a physician, a non-physician practitioner. Therapists, PT, ST, OT, are not eligible to bill evaluation and management services, so they are precluded from using the RPM codes. RTM, or remote monitoring, are actually situated within the medicine section of CPT. So they are not subject to that same restriction and are potentially reportable by physical therapists, occupational therapists, and speech language pathologists. And the RTM codes are not limited to physiologic data. I see a lot of application in the long-term care setting and the potential to monitor activities of daily living, functional status, depression, mood, behavioral symptoms, responses to medications, those types of subjective input by the patient, as opposed to physiologic data that's automatically transmitted from a device that takes those measurements to the providers, could all fall under the RTM codes. Interestingly, in the final rule, Medicare did not give much analysis and much detail to the new RTM codes other than agreeing that they would be covered benefits. So my best thought or suggestion at this point is that we apply, they're structured much the same way as RPM codes are, that other than the performing provider being a broader range of disciplines and credentials for RTM, that we apply many of the same concepts and interpretations that we have available for RPM to RTM, unless and until we get more guidance on those, either through AMA, who issued the codes, or through CMS on how they would cover those, and different documentation expectations. The other thing to keep in mind on the list of covered telehealth services, if you pull that up from the final fee schedule for 2022, you're going to see a lot of services covered as telehealth that could be very beneficial to patients in the long-term care setting outside of a full skilled nursing facility visit. There are behavioral screenings, cognitive assessments, cognitive evaluations, depression screening, alcohol use or abuse screenings, substance use, tobacco screenings, tobacco counseling, cognitive and neuropsychological testing, assessments, and different neuropsych interventions. So there's a wide range of services on the behavioral health telehealth list that you can take a look at. Home visits are also currently on the telehealth list of covered telehealth services. Now that's outside of the public health emergency. That doesn't have a very wide application because home is not an eligible originating site, other than for that flexibility during the public health emergency. And that will extend likely through December 31st, 2023. And it's very likely, I think, that we're going to have some federal legislation that would make that permanent prior to December 31st. But home visits, to the extent home is an eligible originating site for individuals in settings like independent living and potentially assisted living, depending on the interpretation of the guidance, could also be eligible for telehealth services. And then phone visits, where there's not a video component, it's just an audio component, are currently eligible as telehealth services. They fall in the bucket of telehealth that's going to end when the public health emergency ends, not extending all the way to December 31st, 2023. Right, so lots of changes going on in telehealth in the long-term care setting. I'll pause there if we've got any questions.
Rochelle, I don't see any questions. I know there may be some that come in. Want to remind everyone, of course, that you can always submit questions to our email address or on our website. There, Christy just put the email address. It's htrc@kumc.edu. We're very excited about today's presentation, as well as Rochelle's expertise and her willingness to offer that to all of us. So please email us your questions, or you can go on our website and submit a question as well. Please review the FAQ that we have on our website related to billing that answers billing questions that have come in the past. And please join us next Wednesday, November 17th at 12 noon. And we will spend quite a bit of time, obviously, on the new physician fee schedule that will go into effect January 1st. A couple things were referenced today related to that, but we'll go into it even more. And really appreciate Rochelle, as usual, for this excellent presentation. And I hope everybody has a wonderful afternoon, and see you next week.